Welcome back to the deep dive. Okay, today we are putting ourselves directly in the firing line. I'm looking at this massive stack of books on the desk here. We've got Miller, Morgan, and McKyle, Stolting, and the absolute Bible of pharmacology, Katie Tripathi. And the mission today, it's to survive the MD anesthesiology exams at Gujarat University.
It is the ultimate pressure cooker. There's the distinct difference between reading a chapter in a quiet library with a cup of coffee and standing in front of a senior examiner who is just, well, waiting for you to make a fatal error in your management plan.
That is exactly what we are here to prevent. We are tackling a topic that, honestly, it feels like a minefield, alpha-adrenergic blockers.
It really is.
I feel like this is one of those sections where you can be cruising along, you feel confident, and then you say one wrong thing specifically about the sequence of drugs, and the exam is, effectively over.
You absolutely can fail in seconds. We call it a lethal error for a reason. But let's not start with the fear. Let's look at the opportunity here. We've synthesized the source material, fusing the standard anesthesia texts like Stolting with the deep pharmacological detail of Katie Tripathi, and the goal is to create a high-yield roadmap. We aren't just memorizing drug names like Prazosin or Phenoxybenzamine.
No.
We are trying to master the autonomic nervous system.
Because if you understand the alpha receptor, you aren't just memorizing a list. You're understanding how to manage a pheochromocytoma, how to handle that sudden intraoperative hypertension.
Exactly.
And even why that patient on Tamsulosin for his prostate might just, drop his pressure when you induce anesthesia.
Precisely. This topic is a favorite for examiners because it tests your fundamental understanding of physiology. In the Gujarat University format, this appears everywhere. You get the dreaded 20-mark long answer question.
Right.
Usually it's framed as pharmacology of alpha blockers and anesthetic management of pheochromocytoma.
The big one.
Then you get short notes on specific drugs, maybe Prazosin or Phenoxybenzamine, and then the Viva Voice. This is where they grill you. This is where they ask about the mechanism of reflex tachycardia and why you timed your drugs in a certain way.
Okay, so before we get into the weeds of the specific drugs, let's establish the ground rules. Section 1, Introduction and Exam Framing. Let's start with the absolute basics. What exactly are we dealing with here?
In the simplest terms, and this is your opening line in the exam, alpha-adrenergic blockers are drugs that inhibit adrenergic responses mediated specifically through alpha receptors without directly touching the beta receptors.
So they're selective for the alpha side of the street.
Yep.
But let's zoom out to the physiological level. Why do we care so much about blocking these specific receptors? What's the big picture?
Well, think about the sympathetic nervous system's control of blood pressure. It relies heavily, almost entirely, on vascular tone, how tight your blood vessels are clamped down.
Right, the squeeze.
The squeeze. And alpha receptors, particularly alpha-1, are the primary drivers of that tone. When you block them, you interfere with the body's fundamental ability to vasoconstrict.
You're taking your foot off the gas, or rather, you're disabling the engine for vasoconstriction.
That's a good way to put it. And there's a classic concept here. It's mentioned in Katie Tripathi, and examiners love to ask about it. It's called the vasomotor reversal of Dale.
I've definitely seen that term. It sounds like a magician's trick from the 1900s.
It effectively is. It's a beautiful demonstration of pharmacology. Sir Henry Dale showed it way back in 1913. So imagine you have a patient and you inject adrenaline.
Okay.
Normally, what happens to blood pressure?
It goes up. Big spike.
Right, but why? Because adrenaline hits alpha receptors, causing massive constriction, and it also hits beta receptors, causing cardiac stimulation. In a normal person, the alpha effect, that vasoconstriction, dominates.
So you get that pressure spike. Simple enough.
Right. But, and this is the reversal part, if you block the alpha receptors first with an alpha blocker, and then you give the same dose of adrenaline.
So the alpha doors are locked.
The alpha doors are locked. Adrenaline can't get in. So where does it go? It floats over to the unblocked beta-2 receptors in the vasculature.
And beta-2 causes vasodilation, relaxation.
Exactly. So instead of a massive spike in blood pressure, you get a drop. A pressor response becomes a depressor response.
Yeah.
That is the reversal.
Wow. That's a crucial mental model to have. The alpha blocker completely flips the script on what adrenaline does to blood vessels.
And in anesthesia, this matters every single day. We deal with catecholamine storms, with complex vascular surgery, with intraoperative crises. If you don't understand this reversal, you can make a patient dangerously unstable.
So to really get this, we have to go deeper.
We have to. We cannot pass this section without mastering the G-protein coupling. It's non-negotiable.
This brings us to Section 2, alpha-adrenergic receptor physiology. And you've marked this as very high yield. This is the biochemistry part that usually makes people's eyes glaze over.
It is the foundation. If you are drawing a diagram in your series paper, and you absolutely should be, this is where you start. You have two main actors in our story, alpha-1 and alpha-2.
Let's start with alpha-1. Where do they live, and what is their job?
Okay, alpha-1 receptors are postsynaptic. Picture the synapse. They sit on the membrane of the effector organ.
The muscle cell itself.
The muscle cell, exactly. Primarily vascular smooth muscle, but also the radial muscle of the iris, the bladder trigone, and the prostate. Now, the key linkage, and you must write this down, according to both Morgan and Guyton, they are linked to GQ proteins.
GQ. I always use that mnemonic Q-ties cut things. It activates phospholipase.
That's the one. Perfect.
Okay.
It stimulates phospholipase, which cleaves PIP2 into IP3 and DHE. I won't bore you with the entire biochemical cascade for the audio format, but the takeaway is simple and powerful. IP3 leads to a massive release of intracellular calcium from the sarcoplasmic reticulum.
And calcium equals contraction. That's a rule of physiology.
Correct. So alpha-1 stimulation equals vasoconstriction. It squeezes the vessels, which increases systemic vascular resistance and therefore blood pressure.
Okay, that's clear. And the other locations?
In the eye, it contracts the radial muscle, so you get pupil dilation mydriasis. In the bladder, it contracts the trigony and the sphincter, which helps with urinary continence.
So if we block alpha-1, we get vasodilation, pupillary constriction, and relaxation of the bladder neck. That seems straightforward. Now, alpha-2. This is the one that always trips people up because it's not just about simple constriction.
Alpha-2 is the most interesting one, I think.
Yeah.
It is primarily presynaptic. I want you to visualize the nerve terminal again. The alpha-2 receptor is sitting right there on the nerve that releases norepinephrine. Not on the muscle, it is the brake.
The brake on the nerve terminal itself?
Yes, and its G protein is G. The I stands for inhibitory.
Okay, that makes sense.
When alpha-2 is stimulated, it inhibits an enzyme called adenyl cyclase. This leads to a decrease in cyclic AMP, or CAN-AMP. The crucial downstream effect is that it prevents calcium entry into the nerve terminal.
So if calcium can't get into the nerve?
The vesicles containing norepinephrine can't fuse with the membrane.
Which means no exocytosis of norepinephrine. It can't be released.
It's a negative feedback loop, a beautiful piece of biological engineering. The nerve releases norepinephrine, some of it floats around in the synapse, circles back, hits the alpha-2 receptor on the nerve that just released it, and the nerve essentially tells itself, okay, that's enough release for now, shut it down.
That is a brilliant design. It's self-regulating.
Yeah.
So if you stimulate alpha-2, you stop norepinephrine release. We do that with drugs like clonidine and dexmedetomidine.
I got some metholysis.
Yeah. But today we're talking about blockers.
Right, and this is where the light bulb moment happens. This is the critical clinical relevance of selectivity. If you block alpha-2, if you cut the brake lines, what happens? The nerve doesn't know when to stop. It just keeps pouring out norepinephrine into the synapse. It just floods the zone. It spills over, absolutely. And remember, with a non-selective blocker, we have also blocked the alpha receptors on the blood vessels. So where does all that excess spilled over norepinephrine go?
It has nowhere to go but the heart, to the beta-1 receptors.
Causing massive unopposed tachycardia. This is why the distinction between a selective and a non-selective blocker isn't just academic. It's the difference between a controlled heart rate and a runaway train.
Which brings us perfectly to Section 3, classification. This is core exam territory. How do we break these down without just memorizing a long, confusing list?
We follow the classification found in Katie, Tripathi, and Stolting. It's logical. We divide them into two main camps based on that very selectivity we just discussed. Non-selective alpha blockers and selective alpha blockers.
Okay, let's start with the non-selective ones, the heavy artillery, the sledgehammers.
These are the agents that block both alpha-1 and alpha-2. The big names here, the ones you must know, are Phenoxybenzamine and Phentolamine.
And because they block alpha-2, they are cutting those brake lines we just talked about. That's the key takeaway.
That is the absolute key. So clinically, what do you see? You get the desired vasodilation from the alpha-1 block, but you pay a price. You get severe reflex tachycardia because of that alpha-2 block, which is dumping norepinephrine onto the beta receptors of the heart.
Now, within this non-selective group, there's a huge chemical difference, right? It's almost like a difference in commitment levels.
That's a very good way to put it.
Yeah.
Phenoxybenzamine is a beta-haloalkylamine. This isn't just trivia. It explains its mechanism. It binds covalently to the receptor.
A covalent bond, that's a strong, permanent bond.
It's a non-equilibrium blockade. Think of it as a marriage with no possibility of divorce. Once it binds, it never lets go. That receptor is alkylated and, for all intents and purposes, destroyed. The body has to physically synthesize new protein receptors to recover function.
So it's the sledgehammer. Once you swing it, the damage is done and lasts for days.
For days. Exactly. Now, contrast that with phentolamine. It's an imidazoline derivative. It is an equilibrium or competitive blocker.
So it's reversible.
It binds, it blocks, but it can unbind. It's a casual date, not a marriage.
Yeah.
The effect is dose-dependent and short-acting.
Okay, so phenoxybenzamine for the long game, the preoperative prep. Phentolamine for the short game, the intraoperative crisis. What about the other camp, the selective alpha-1 blockers?
These are your zosins.
Yes.
That's the suffix to remember. Prazosin, Prazosin, Doxazosin. And then you have the more uroselective osins, like Tamsulosin and Alfuzosin.
And their whole mechanism, their advantage, is what they don't do, right? It's about the brake line.
Precisely. They block only alpha-1. The presynaptic alpha-2 receptor is spared.
So the brake is still working.
The brake is intact. The nerve can still regulate its own norepinephrine release. So while you still get some reflex tachycardia just from the drop in blood pressure activating the baroreceptors.
Which is a normal physiological response.
A normal response. But you don't get that additional massive catecholamine dump that you see with the non-selectives. The tachycardia is much, much less pronounced.
That is a huge clinical advantage. I see Tamsulosin is listed here as having a subtype selectivity. Can you expand on that?
Yes, this is a more modern development and a great point for an exam answer. It turns out there are subtypes of the alpha-1 receptor. Tamsulosin is fascinating because it is selective for alpha-1A receptors.
And where are those found?
They are concentrated in the prostate and the bladder neck. The vascular receptors, the ones that control blood pressure, are largely alpha-1B.
So it targets the urinary system without tanking the blood pressure.
To a large extent, yes. That's why Tamsulosin is a first-line drug for BPH-benign prostatic hyperplasia, because it can relieve the urinary obstruction, help the patient pee, without causing as much dizziness and postural hypotension.
Brilliant. And just for completion's sake, are there selective alpha-2 blockers?
Yes. Yohimbine is the textbook answer. You should know the name. Clinically, it's rarely used now. It does the opposite of clonidine. It increases sympathetic outflow by blocking the brake. Historically, it was touted as an aphrodisiac or for erectile dysfunction, but for your exam, just know it exists as a selective alpha-2 antagonist.
Got it. Okay, that classification is clear. Now let's move to section 4. Pharmacokinetics. If I'm prescribing these or using them in the OT, I need to know how they move through the body. The timing is everything.
It is everything. Let's go back to our two heavy hitters, Phenoxybenzamine versus Phentolamine. Phenoxybenzamine is usually given orally as capsules. It can be given IV, but it's a vesicant, it's an irritant, so we really try to avoid that if possible.
And absorption from the gut.
It's notoriously incomplete and erratic. It's not a very elegant drug in that sense. But the key, the absolute key for anesthesia, is the onset and duration.
Right.
Because it has to be absorbed, metabolized, and then form those covalent bonds we mentioned. The onset is slow. It can take about an hour to even start working, with the peak effect much later.
Right.
But the duration is massive.
Massive. The half-life of the drug itself isn't that long, but the biological effect lasts for 3 to 4 days.
Because we have to literally grow new receptors. This sounds like it completely dictates how we prep a patient for, say, a Pheochromocytoma surgery.
It absolutely dictates the entire strategy. You don't use phenoxybenzamine for minute-to-minute blood pressure control in the operating theater. You use it to methodically and slowly stabilize the patient for weeks before they ever see the inside of an OT. You are creating a stable floor of alpha blockade.
Okay, and in contrast, phentolamine.
Phentolamine is your crisis drug. It's given IV or IM. Its onset is almost immediate, within a minute or two. And its duration is short. We're talking 10 to 15 minutes.
So it's perfect for intra-op.
It's designed for it. Imagine the surgeon is handling the tumor and the BP spikes to 240 over 120. You don't want a drug that lasts 3 days. You want something that works now and is gone in 10 minutes, so you're not dealing with refractory hypotension later. It's titratable.
Fast on, fast off. That makes perfect sense. And the selective ones like Prazosin, and Doxazosin are primarily oral agents. They undergo significant hepatic metabolism, what we call first-pass metabolism. The relevance for us in anesthesia is really identifying patients who are on these chronically for hypertension or BPH.
What's the specific concern there?
Their vascular system is already primed. It's accustomed to being dilated. Their sympathetic tone is already blunted. When we come along and induce anesthesia with our volatile agents, which are also vasodilators,
You get a synergistic effect.
a profound drop in blood pressure. They can crash on induction if you're not prepared with fluids and pressors. You have to anticipate it.
Okay, now let's talk about the effects on the body. This is section 5, pharmacodynamics. You called this the money section for understanding the clinical picture. The cardiovascular system is obviously the big one.
It's all about resistance and capacitance. First, resistance. The blockade of vascular alpha-1 receptors causes potent vasodilation, and it's important to remember it affects both the arterioles and the veins.
So it reduces both preload and afterload.
Excellently put. The reduction in systemic vascular resistance, the SVR, is what leads to the fall in blood pressure.
And when is this fall in blood pressure most dangerous, most pronounced?
Two situations. When the patient is hypovolemic or when they are standing up. This is the mechanism of postural or orthostatic hypotension. If the tank is empty or if gravity is pulling blood down into the legs, taking away that compensatory vasoconstriction causes a collapse in venous return.
And the brain doesn't get enough blood. Dizziness, syncope.
Exactly. Now, we touched on reflex tachycardia, but I really want to clarify the two distinct mechanisms again because I guarantee an examiner will ask you to separate them.
Okay, let's nail this down. Mechanism
number 1 is the baroreceptor reflex. This happens with all vasodilators, selective or non-selective. The blood pressure drops, the baroreceptors in the carotid sinus and aortic arch sense it, and the brain sends a signal via the sympathetic nervous system to increase heart rate to compensate.
Simple compensation? What's mechanism 2?
Mechanism 2 is the pharmacological one, and it is specific to non-selective agents like Phenoxybenzamine and Phentolamine.
The brake line.
It's the blockade of that presynaptic alpha-2 brake. This causes a direct, uncontrolled leakage of norepinephrine from the nerve terminal right onto the beta-1 receptors of the heart.
Got it. So it's a double whammy with the non-selectives. You get the compensatory reflex plus a direct catecholamine dump.
Okay.
What about venous capacitance? You mentioned that.
Yes. This is often overlooked, but very important. Alpha blockers, by dilating the veins, dramatically increase venous capacitance. Basically, the veins get floppier, it can hold a lot more blood.
So blood pools in the periphery?
It pools in the periphery, which means less blood is returning to the right side of the heart. Decreased venous return means decreased preload, which, by the Frank-Starling mechanism, means decreased cardiac output. This is especially true in the upright position.
What about other organ systems? What are the common side effects we see?
Okay, let's run through them. In the eyes, you block the alpha-1 receptors on the radial muscle of the iris. This leads to unopposed parasympathetic tone, so the pupil constricts. That's meiosis.
Okay.
The nose, this is a very common patient complaint. Nasal congestion. The mucosal blood vessels dilate and swell up, and patients feel like they have a bad cold or stuffy nose all the time.
And the GU system.
In the genitourinary system, you get relaxation of the smooth muscle in the bladder trigone and the prostate capsule. This reduces the resistance to urine outflow, which is precisely why we use them for BPH.
Okay, let's move on to section 6, clinical uses. We've touched on BPH already, but let's list the big ones for the exam in a structured way.
Hypertension is the classic one, but it's important to note that they are not first-line agents anymore. Large studies like the ALAT trial show they weren't as good as other classes at preventing major cardiovascular events.
So they're more of an add-on therapy now.
An add-on therapy, exactly. However, they are crucial for specific hypertensive situations. For example, clonidine withdrawal. If a patient abruptly stops taking clonidine, an alpha-2 agonist, they get severe rebound hypertension. Alpha blockers are a key part of managing that.
And another classic board question, the cheese reaction.
But the cheese reaction, yes. When a patient on an MAO inhibitor eats tyramine-rich foods like aged cheese or red wine, they get a massive release of catecholamines. Phentolamine can be used to treat that hypertensive crisis, but the absolute indication, the star of the show for any anesthesia exam,
Has to be pheochromocytoma.
Pheochromocytoma, a catecholamine-secreting tumor, usually of the adrenal medulla. This is the condition that brings together all the physiology and pharmacology we've been discussing. It is the ultimate test.
And BPH, just to recap.
Benign prostatic hyperplasia, specifically drugs like Tamsulosin or alfuzosin. They relieve what we call the dynamic component of the obstruction by relaxing the smooth muscle in the bladder, neck, and prostate.
What about peripheral vascular disease?
Conditions like Raynaud's phenomenon, where you get vasospasm in the fingers and toes. Miller and other texts note that the efficacy is often disappointing, probably because many of these conditions have a fixed structural component, not just spasm, but it is a textbook indication. The idea is to vasodilate those spastic vessels.
All right, let's get into the operating theater. This is sections 7 and 8 of our breakdown, and frankly, it feels like the most critical part. Anesthetic management in pheochromocytoma. My first question is, why do we spend weeks prepping these patients? Why not just take them to the OR, take the tumor out, and be done with it?
Because the unprepared patient is a loaded gun.
Mm-hmm.
You have to understand the chronic physiology. A patient with a pheochromocytoma has been living with intense 247 catecholamine exposure for months or years.
Okay.
This causes persistent, severe vasoconstriction. This intense squeeze on the vasculature effectively squeezes the plasma volume out of the blood vessels and into the interstitial space.
So even though their blood pressure is sky high, they are actually volume depleted.
Profoundly. They're chronically dry. Their tank is empty. If you induce anesthesia without preparation, the anesthetic agents will cause vasodilation, and they will crash. If you just take the tumor out, the source of catecholamines vanishes, and the vasodilation will cause immediate catastrophic cardiovascular collapse.
So the alpha blocker isn't just lowering the blood pressure. That's not its main goal.
No, that's a secondary benefit. The primary goal of preoperative alpha blockade is to relax the constricted vasculature gradually over 10 to 14 days. This vasodilation allows the intravascular volume to expand back to normal. You are literally refilling the tank.
And there is a golden rule here, one that is written in bold, underlined, and with exclamation points in every single textbook.
Alpha blockade must precede beta blockade.
I want you to say that again just so it sinks in.
Alpha before beta. Always. A, then B. It's as simple as the alphabet.
Let's play this out. What happens if a nervous student in a Viva suggests giving propranolol first to control the patient's tachycardia?
It is an instant fail. You can pack your bags and come back next year. Here is the mechanism you must be able to articulate. The patient has extremely high circulating levels of adrenaline and norepinephrine.
Okay.
These catecholamines are stimulating alpha-1 receptors, causing vasoconstriction, and beta receptors, beta-1 on the heart, causing tachycardia, and beta-2 in the peripheral vessels, causing some vasodilation. If you block the beta receptors first,
You take away the heart's ability to cope, and you block the only source of vasodilation, the beta-2 receptor.
exactly, you block the vasodilatory beta-2 receptors and the cardiac support from beta-1. The circulating catecholamines now have nowhere to go but the alpha-1 receptors. You get unopposed, massive, catastrophic vasoconstriction.
So the blood pressure, which was already high, skyrockets.
It doesn't just skyrocket, it precipitates a hypertensive crisis that can cause a stroke, a myocardial infarction, or acute heart failure. You're forcing the heart to pump against a brick wall that you just built.
Unforgettable. Okay, so we establish alpha blockade first. How do we know it's working? How do we know the patient is ready? What are the criteria? I believe Roizen established these.
Yes, the Roizen criteria are the classic exam answer. You should be able to list them. 1, no blood pressure reading greater than 16/90 for the 24 hours preceding surgery.
Okay, that's blood pressure control.
2, orthostatic hypotension should be present, but not excessive. A drop in systolic pressure of about 15 millimole Hg when standing is a good sign.
Wait, we want them to have postural hypotension. That seems counterintuitive.
We do. If the patient gets a little dizzy when they stand up, it is clinical proof that their alpha receptors are effectively blocked and, more importantly, that their intravascular volume is now re-expanded.
I see. It's a sign of successful therapy. What's number 3?
No ST segment or T-wave changes on the ECG for at least a week, preferably 2. This indicates the myocardium is stable and not ischemic.
And the drugs of choice for this long-term preparation.
Phenoxybenzamine is the classic gold standard answer. You usually start a low dose, say 10 milligrams to twice a day, and titrate it up over 10 to 14 days. It provides a stable, smooth, non-competitive blockade.
Are there alternatives?
Yes, some centers prefer selective alpha-1 blockers like Prazosin or doxazosin. The argument is that they are shorter acting and might cause less problematic postoperative hypotension. But for an exam, phenoxybenzamine is the safest, most classic answer.
Okay, let's talk about the surgery itself, the intraoperative management. What are our hemodynamic goals in the theater?
Our goal is stability. We need to expand blood volume aggressively with crystalloids and colloids. The patient will need a lot of fluid as the anesthetic causes more vasodilation. We need to prevent the two big swings, the massive hypertension during tumor handling.
When the surgeon manipulates the tumor and squeezes out more catecholamines.
Correct. And then the profound hypotension that happens post-ligation.
Post-ligation. That's after the tumor's blood supply is cut.
Exactly. Once the adrenal vein draining the tumor is clamped, the source of catecholamines is gone. The plasma levels can drop to near zero almost instantly. If you still have a long-acting alpha blocker like phenoxybenzamine on board,
You're in trouble because you have no catecholamines and your receptors are still
the
blocked.
bottom falls out. You have massive vasodilation with no sympathetic tone to counteract it. You need to be ready with fluids, vasopressors like vasopressin or norepinephrine, and have multiple large-bore IVs.
Okay. Briefly, you mentioned controlled hypotension earlier. Is this a common use?
Conceptually, yes. Alpha blockers can lower blood pressure to reduce bleeding in, say, neurosurgery or major orthopedic surgery. But in modern practice, we have much better, more titratable agents like nitroglycerin, sodium nitroprusside, or short-acting beta blockers like esmolol. But historically, it's relevant.
Let's pivot now to Section 9. Adverse effects and complications. We've mentioned a few in passing, but let's be systematic for the exam.
Orthostatic hypotension is the big one. We've talked about it. With Prazosin specifically, there's something called the first dose effect. Severe syncope, fainting, can occur after the very first dose.
That sounds dangerous. How do we mitigate that?
It's simple patient education. We start with a very low dose, and we advise patients to take the very first dose at bedtime. That way, if they feel faint, they are already lying down.
Practical advice. Nasal congestion we mentioned, a nuisance, but very common.
Yes. And sexual dysfunction is another important one to counsel patients about, particularly younger men. You can get an inhibition of ejaculation. With Tamsulosin specifically, you can get retrograde ejaculation.
What's happening there?
The bladder neck relaxes so much due to the alpha-1A blockade that during orgasm, the ejaculate goes backward into the bladder rather than out through the urethra.
That's certainly an important side effect to be aware of.
Very much so. And then there's fluid retention, which may require concurrent use of a diuretic, and of course reflex tachycardia, which, as we said, can precipitate angina in patients with underlying coronary artery disease.
Moving to Section 10, contraindications. When should we absolutely not use these drugs?
Top of the list, in big red letters, is hypovolemia. Let me give you an expert warning. Never give an alpha blocker to a dry patient.
Why is it so dangerous?
If a patient is actively bleeding or severely dehydrated, their sympathetic tone, their vasoconstriction, is the only thing keeping their blood pressure high enough to perfuse their brain and heart. If you block that compensatory vasoconstriction, you will cause cardiovascular collapse.
What about the elderly population?
You have to be extremely cautious. They are at a very high risk of falls due to orthostatic hypotension, which can lead to hip fractures. There are also risks of cerebral hypoperfusion if their blood pressure drops too low, potentially causing confusion or even a stroke.
And interactions. This is Section 11. We are anesthesiologists. We mix drugs for a living. This is critical.
Be very careful with our volatile anesthetic agents, like isoflurane and sevoflurane. They are themselves vasodilators. If you combine them with a patient who is already on an alpha blocker, you can see profound refractory hypotension on induction.
So the plan is to induce slowly, have fluids running wide open, and have a pressor ready.
Absolutely. You need to be ahead of the curve. And what about the lifestyle drugs? PDE5 inhibitors like sildenafil, which is Viagra.
Oh, that's a big one.
A huge issue. Both alpha blockers and sildenafil cause vasodilation through different mechanisms. If a patient on an alpha blocker for their prostate takes sildenafil, they can have a sudden, dangerous, and sometimes fatal drop in blood pressure. You must ask about this in your pre-op assessment.
Okay, we are in the home stretch. Section 12, common exam questions and Viva traps. If I'm sitting across from you in the exam, what are the traps I absolutely need to avoid falling into?
We've already covered the number one, instant fail trap.
The beta first error.
The beta first error. You must never make it. Another common one is the mechanism of reflex tachycardia.
The trap is failing to mention the presynaptic component.
Yes. If you just say baroreceptor reflex, you only get half marks. A good candidate will say there are two mechanisms. The first is the baroreceptor reflex. The second, which is specific to non-selective agents like Phenoxybenzamine, is the blockade of presynaptic alpha-2 autoreceptors, leading to increased norepinephrine release and direct beta stimulation. That's a distinction that separates the average student from the top one.
What about a question like physiological versus pharmacological antagonism? How does that apply here?
An examiner might ask, how does phenoxybenzamine differ from phentolamine in terms of reversibility? This is where you need to use the correct terminology. You say, phentolamine is a competitive antagonist which results in an equilibrium blockade. Phenoxybenzamine is a non-competitive antagonist that forms a covalent bond, resulting in a non-equilibrium blockade.
Using those key terms shows a deeper understanding.
It shows you've read the book and you understand the chemistry.
And if an examiner asks a really tricky clinical scenario and you're just stuck, what is the safe answer?
The examiner's favorite safe harbor, and it shows good clinical sense, is always to say two things. I would titrate all drugs to clinical effect, and my first priority would be to ensure and restore adequate intravascular volume. You can rarely go wrong by prioritizing volume status before you start vasodilating a patient.
Section 13 is crucial for the theory paper, diagrams and exam presentation. You've said visuals get marks. What should I be drawing?
You absolutely must draw. It breaks up the text and shows the examiner you can think visually. You need three things. First, the receptor diagram.
Okay.
Draw a simple nerve terminal, a synapse, and an effector cell. Show norepinephrine being released from vesicles. Draw the alpha-1 receptor on the muscle and show that it leads to contraction. Then, crucially, draw the alpha-2 receptor on the nerve terminal itself, showing that it causes a negative feedback loop. Label the G proteins, GQ for alpha-1, G for alpha-2.
What's the second diagram?
A simple comparison table. 3 columns. Non-selective, e.g. Phenoxybenzamine, selective alpha-1, e.g. Prazosin, and maybe selective alpha-2, yohimbine. Compare their mechanism of action, effect on heart rate, and primary clinical use.
And the third?
The Pheochromocytoma management flowchart. This is a guaranteed winner. A series of boxes with arrows, diagnosis pre-op alpha blockade, 10-14 days, volume expansion and hydration, beta blockade, only if significant tachycardia persists after alpha blockade, surgery with invasive monitoring, post-op management of hypotension.
That is a solid, practical plan. And how should I structure the 20-mark long answer?
Headings are your best friend. They guide the examiner through your thoughts. Use them. Introduction, classification, pharmacokinetics, pharmacodynamics, clinical uses, detailed anesthetic and management of pheochromocytoma, and finally, adverse effects.
Perfect. Okay, let's do a rapid-fire recap to seal all of this in. This is our final section, section 14, summary and exam conclusion.
Ready when you are. First principle. Alpha blockers cause vasodilation, the receptors. Alpha-1 is the effector, GQ. Alpha-2 is the brake, the workhorse drugs. Phenoxybenzamine is irreversible, non-competitive, and long-acting. It's for pre-op pheochromocytoma preparation, the crisis drug. Phentolamine is reversible, competitive, and short-acting. It's for intra-op hypertensive crises. Those selective agents. Prazosin and Tamsulosin are selective alpha-1 blockers. They're used for hypertension and BPH, and they cause much less reflex tachycardia, a key side effect. Prazosin has that famous first dose effect, causing syncope, the specialist. Tamsulosin is uroselective because it targets alpha-1A receptors in the prostate.
And the final take-home messages for the exam, the two big principles.
Alpha before beta, and my personal favorite, fill the tank before you open the pipes. If you remember those two principles, you will be safe in the operating theater and you will be safe in the exam.
Any final thought for the person cramming for this exam?
Understand the receptor physiology. I can't stress this enough. If you truly know that alpha-1 constricts and alpha-2 inhibits release, you don't need to memorize a long list of side effects. You can predict them. You can predict the tachycardia, the nasal congestion, the postural hypotension. Deriving the answer from first principles is always better than just memorizing it. Good luck with the Gujarat University exams.
Thank you. That was a serious high-yield drill. I'm going to go practice drawing those receptor diagrams in that flowchart right now. To our listeners, keep learning, stay curious, and we'll see you in the OT.